and gentlemen, it's my pleasure to welcome you to this symposium, which is entitled TricValve Addressing the Unmet Need for Patients with Right Heart Failure and Functional Tricuspid Regurgitation, Real-Life Clinical Outcomes. This session is sponsored by Orbis and HPNF, and really like to thank them at that moment for supporting this. My name is Michael Haude. I'm here to chair this session and to facilitate this session. And I want to take the opportunity to give you a little brief introduction to the topic. Tricuspid regurgitation is a bit under-recognized disease, honestly speaking. Nevertheless, it is a very significantly occurring disease. We know that it is frequent, but happening, for example, in the US and being present in about 1.6 million people. And I think the relation in Europe is not difficult. We know if we need to take surgical options to treat it, the mortality in these cases is quite high, around 9%. Therefore, a demand was there to create and develop multiple transcatheter devices to address the TR in high-risk patients. Now, if we look what has been developed as a percutaneous approach to treat tricuspid regurgitation, we have devices that perform a leaflet repair by reducing the leaflet coaptation gap, edge-to-edge techniques. We have annuloplasty devices that intend to reduce the annulus, which is dilated in significant TR. And then we have valve replacement, orthotopic one, as well as heterotopic one. And the TricValve system, the TricValve Transcatheter Bicaval valve system, this is a really attractive new opportunity to use the heterotopic approach. And this is what we're going to deal with today in this symposium. Now, this is the system you can see here, which consists of two valves which are implanted into the superior and inferior vena cava, and they are intended to treat patients with a TR grade 3, 4, and 5 with a severely dilated tricuspid annulus and a large coaptation gap. Now, the objectives of this session are to learn about the latest treatment option for patients with severe tricuspid regurgitation, to explore the supporting clinical evidence we have for TricValve, and to understand how the TricValve Transcatheter Bicaval valve system can improve the quality of life in these patients. Now, this is the outline of the program. We're going to have a live-in-the-box case recorded by Jorg Hausleiter and being presented by him. Then we're going to give an overview on the clinically available data and trial designs given by Rishi Puri, and some real-life experience from the center in Aalst by Liesbeth Rosseel. And then we're going to have a final discussion, and then I'm allowed to wrap up the session. The speakers will also function as discussants on the panel, together with additionally Katharina Kiss, which is also with us here. So you have the opportunity via the app to pose questions. Please do that. Use that opportunity. At the end, we have this discussion session, and we will be more than happy to answer as many of these questions as possible. So without any kind of further delay, Jorg, I'd ask you to present your live-in-the-box taped case. Thank you very much.
Yes, thank you very much, Michael. Dear colleagues, it's a pleasure to be here and to share with you a case which we treated a couple of weeks ago. These are my conflicts of interest. This is a video around 70 minutes long. We can stop this anytime, so please feel free to step up and ask questions. Then we can stop this in between. As just said, so this is my colleague, Michael Stocker. We have an echocardiographer, Michael Neubauer, as you will see, and the Federholzer, she was the anesthesiologist. Now, this concept of heterotopic tricuspid valve replacement has a history and has been developed early on and evaluated in animal models by Alexander Lauten and Hans Figula. And you see here a publication from 2018, already summarizing their first clinical experience. And the theory behind is that we're going to separate the back, the upper and lower extremities from the heart, so that there's no cable backflow into the upper and lower body halves. The TricValve system is a pre-mounted valve system, which is here in this catheter tip. It's 27 French, has a soft tip here. And then very simply and easily, by turning this wheel, which is down here, we can unsheath the stent in the respective positions, in the upper cable vein and in the lower cable vein. Let's move a little bit further. There are currently 3 different sizes for the upper valve. You see here the 25, the 29, and the 33 millimeter device. The upper stent has like this little belly here, which we usually place in the confluence of the anonymous vein and the right subclavian or jugular vein. Then you see here that the lower part, the lower 50% more or less, is covered, so that we have here a nice sealing, and this is also here in the lower part where the actual valve is. Then we have 4 sizes for the lower cable vein, the inferior cable vein, which is coming here in a second, hopefully. Here it is. I'm going to stop this again. From 31 to 45 millimeters. Again, now in the upper part, as you can see it also in this picture up here, this part is sealed. The sealing is around 22 millimeter in height, depending on the different sizes. And this is also where the valve is located. And then we have the stent, which facilitates a good anchoring of the device in the correct position. Now we're going to present the patient note in the next few minutes here. This is a patient, as you will see in a second. He's 82 years old. He's symptomatic. He has New York Heart Class 3. The walking distance in the 6-minute walking test is significantly reduced, less than 100 meters. And as you will see in the echo assessment, he has a severe or torrential TR. He has a previous CABG surgery, left LAA resection in 2009, a cardiorenal but also cardiohepatic syndrome with a GFR below 30 and 35 and 40 milliliters per minute, elevated bilirubin, alkaline phosphatase, and gamma GT. Chronic atrial fibrillation, as most of those patients have, arterial hypertension, hypercholesterolemia. So we discussed, of course, this patient in the heart team. And due to these comorbidities, we thought that this patient, was jumping here, is too fast, is not a good candidate. We're calculating for a surgical procedure. The TRI score is a very recent surgical score, and it predicts the mortality. And in this patient, the predicted mortality was 22%. We did the right heart cath in this patient. The PA pressure was 50 in systole, a significant V wave in the right atrium of 46, so significant backflow. As you can see, in summary, it's a moderate post-capillary pulmonary hypertension. This is the medication which the patient was taking. Not very high dose of toracemide as the diuretic, but the combination of hydrochlorothiazides and toracemide, there was no possibility to increase this dosage, because then either he was hypovolemic and with low blood pressures, or the kidney function deteriorated even further. Now this is here the echo, the 4-chamber view. This is the significant dilated right ventricle. You can appreciate the significant TR with the large coaptation gap already. The MR and TE is moderate, not severe. And then, as you can hopefully see in a second, also on the right side, there is the significant large jet over the entire commissure from the anteroseptal to the posteroseptal line of coaptation. This is the 3D, and I'm going to stop that here because this is also very important for our workup of how we're going to deal with these patients. You see here in this 3D view, the septal leaflet, the anterior leaflet, and the posterior leaflet, and you can appreciate the large coaptation gap between the postural and septal leaflets. For this workup, we have to understand that for other therapies, for an edge-to-edge therapy, for example, we would consider patients suitable for an edge-to-edge if the coaptation gap is probably below 8 millimeters, not above 8 millimeters. Here, we had a coaptation gap somewhere around 10 millimeters. And also the postural septal line of coaptation, if the origin is here, the hole is in its lower part, this is also less favorable for an edge-to-edge repair, and we see usually a higher recurrence rate for this patient. We also evaluated this patient as a next step for an orthotopic valve replacement within one of the ongoing studies. But due to this large annular size, this patient was also not deemed favorable for an orthotopic valve replacement. So the next option then is to consider this heterotopic valve replacement system, as you will see in the next few minutes. So let's see. Now we did the CT analysis. It's important to measure the caval vein size of the superior caval vein and the inferior caval vein. And with respect to these measurements, we get then the information of what kind of valve size. And in this case, a 29 millimeter for the upper one. And here's the lower assessment of the lower caval vein. And here a 35 millimeter caval vein was planned to have some oversizing with a good positioning of the valve. Now we're jumping into the procedure here. What you're going to see, this patient was not in intubation, but in analgesic sedation. We don't need to have a TE probe during the procedure. I prepared here both groins. On the left groin, you see an arterial access, but also a femoral access in the femoral vein access for a pulmonary catheter. This is the white catheter in here. And on the right side, which we used then also for the TricValve placement, also a vein access. Now we're placing here the pulmonary artery catheter in the right pulmonary arteries, which serves us also as an anatomic landmark. And I'm doing injections here into the right jugular vein, and you see here the flow of the contrast in the superior caval vein, and you can also appreciate here the confluence of the unmet vein. So because we don't want to obstruct that, so the vein with our stent. Now, the fluoroscopy is very helpful for the placement of the first stent, as you will see in the second. So I'm placing here a plus extra stiff wire into the right jugular vein. I prepared this access here. That's what I'm showing here is first with a pro glide so that we can close the access at the end of the procedure. But then in addition to that, I'm placing here a set suture, which I can, and I leave the suture still in place. So I can use this by pulling it tight, that we can avoid the significant backflow of the blood during the procedure. Now we're doing the dilatation of the access up to 26 French. Usually this is without any problems. And with each taking out of the dilators or then changing, I pull on the sutures so that we have no blood. You see here the nice system, the tip of the catheter, the pre-mounted system, so it comes already, everything is prepared, it's a dried bovine pericardial valve. And then here you see how easy the system can be introduced. And maybe I'm going to stop here also for a second. You see now here the system, this is the nose cone. Here is the valve system in this pre-mounted sheath. You can appreciate more or less these two indentations. In between is this belly of the valve. And this belly, as I said before, we want to place so that we have some blood flow from the left side over the anonymous vein into the superior caval vein, so that we're not obstructing this with our system. So we want to place this rather high, but not too high, so that we are avoiding this, avoiding any obstruction. The pulmonary catheter serves, as I said, as the other landmark, so that we want to be above this pulmonary artery catheter, so that the valve is not dropping below the pulmonary artery catheter. So this serves us and gives us a little bit more additional stability of the valve. Then the procedure is rather simple, as you will see. Just by pulling this wheel here, we're going to unsheath the stent. This is being performed in several steps. You see now in a few seconds it starts just flaring, and I'm trying to orientate myself here by the ribs and the subclavia, so that this upper stent part is more or less located in here. Now you see that the belly has already been expanded. You always have to take a little bit of time until the stent is getting accustomed to the temperature. Then it's expanding even further. So you can't do this in just 30 seconds, but probably the entire procedure to expand this valve is always stopped for a couple of minutes after each of those steps, and it takes about 10 minutes to release the entire stent. It's been anchored with three anchors in the delivery system, and then you're going to place this very carefully, one anchor after the other is being released. Here's one anchor is in, but the other two are still out, and the other two are still in the system. Now the other anchors came out at this point. Again, we have to wait a little bit, like a minute or so, and then we can slowly retract this catheter system. We don't want to put some tensioning on the stent, of course, so that it is not dropping into the right atrium. And then after taking this out, then we remove the pulmonary catheter and insert it now a pigtail catheter into the hepatic vein, so that we can also see the blood flow from the hepatic vein into the inferior caval vein. Now this is the exchange now for the inferior stents, valve stent system. And as you have seen, perhaps now with this pulling tight of the set suture, there's almost no backflow, although we have a pretty significant hole of 28 French or 27 French in the groin. Now this stent, I'm going to stop this also here again so that you can appreciate the fluoroscopic appearance, is again mounted in this delivery system, pre-mounted as the upper one. It has a first part up here. This is the covered part, again roughly around 22 millimeters, and this is the lower part, which is uncovered, and the valve is in this upper part. During the placement, and also here we're doing, and I'm just replaying the angio of this, of the flow of the blood from the hepatic vein, so that we can appreciate, probably here is the transition from the hepatic vein into the right atrium. We're discussing about the height, what is probably the best. Well, usually there's a little bit of oblique transition from the diaphragm, so we need to be sure that we are high enough on one side, but also not too high for the other side. and we can still retract the system, also the upper one, during the release, but we cannot insert the valve. So starting higher is easier and pulling back, but not the other way around. Now you see the system is flaring again in this position. We are orientating ourselves here also with the spine. And then by transthoracic echocardiography, we can appreciate now here the inflow part of the inferior caval vein into the right atrium. This is the stent, this is the wire. We can measure this distance. Usually we want to have like a height of around 15 to 17 millimeters, so that we get a good sealing. Right now, it's just the upper part is opened, not the lower part. So there is still some backflow as sometimes in here, but as soon as we further expand the stent, as you will see, we're trying to see that we're really generating here a good sealing. Now the valve is already a little bit further expanded. We're checking again before we fully release that we are not obstructing the hepatic veins. Then you can also pull out the pigtail when you're certain that you have the correct height, and then the three anchors again are being released. Here's again a control by echocardiography. Now we have already a significant portion of the stent expanded. Here's almost no backflow into the hepatic veins. So there we have a good pressure separation of the right atrium to the caval vein. And now we see that the stents are being, or the anchors are being released. Again, this is the entire procedure for one stent, also for the low one, is somewhere around 10 minutes with some in-between breaks. There's no, all the anchors are being released. You have, and then we can also pull back the catheter, the delivery catheter system, which you see right now. I'm going to jump a little bit further. Now, how can we assess our procedure? Of course, we can see by echocardiography if we have some backflow into the hepatic vein. Here I'm performing a right atrial injection to see if there's some contrast is coming back into the upper or lower caval vein. It's not displaying here well, but we had a very good sealing. And what you can also appreciate is the hemodynamic response. With this placement, you get a significant further ventricularization of the right atrial pressure. Now the right atrial pressure in systole is around 70 millimeters of mercury. But in a second you will see that I'm pulling back the catheter to the below the caval vein, below the stent into the inferior caval vein, and you see the significant pressure drop. So they have a good separation of the right atrium to the lower body half. With this, we're almost done in this procedure. We're closing the groin with the ProGlide, which was already delivered. Here's an echocardiographic result, which matches very well the hemodynamic response. There's almost no backflow. A little bit is coming through the valve in here, but this is insignificant. And I jump a little bit further. This is then it's very simple. The patient is going back to the ICU ward. What some of the patients are experiencing is some significant shoulder pain in the first hours and days after the procedure because the phrenic nerve is somewhat a little bit stressed by the stent. This is something what we need to tell our patients up front, but usually after the second or third day, this also goes away and the patient is significantly improving. Thank you very much.
Thank you. Thank you, Jorg. We're going to come back to you during the discussion, and now we move on in the program and ask Rishi Puri to give us an overview on the available clinical data and trial design, both from the EU as well as the US perspective. Rishi.
Thanks, Michael. It's good to see a full room late in the day. It's a good sign. Here are my disclosures. So in 5 minutes, I have to tell you all about the data and all about the trial, the pivotal trial design. Most of the data that you have thus far reflects what's been done in the Tricus first-in-man study as well as the Tricus EuroCMAC study that was released in JACC Interventions today as a simultaneous publication, so very exciting and a very timely release. So when you look at both of these, the first-in-man and the CMAC trial, you see a very typical severe TR population comorbidity kind of characteristics. These are sick patients, a quarter have pacemakers. Many of them have had prior valve disease, and almost all of them are on Coumadin or a DOAC for atrial fibrillation. So really no surprises here for those of us who are involved in treating these patients with other transcatheter tricuspid valve technologies. Procedurally, you've seen Dr. Hausleiter show you a beautiful example of a smooth procedure done under local anesthesia, transthoracic echo, skin to skin, in probably 25 to 30 minutes. And so surprisingly here, you don't really see any major catastrophes during the procedure. You're not doing fancy maneuvers or acrobatics like some other devices require you to do, and you can have a very streamlined sort of short learning curve and a very streamlined, nice procedure with no major dramas. Again, this reflects the very first human results, and then largely in Spain, some really nice results moving on to the CMAC trial. What's really important to appreciate here is the improvement in patients' well-being, which is the number one goal of these therapies. When you talk to these patients, and even when you talk to the FDA, everyone is in agreement that extending someone's life in this particular setting is not necessarily the goal of these patients. When you talk to these patients, they want to feel better, they want to be more functional, and they don't want to be in hospital. And so functional data is going to emerge as being a very important parameter in the tricuspid space. And this is a space that's kind of moving forwards. And David Cohen, who really sort of started off with the KCCQ score, is working with the FDA and some of the other trials, and perhaps with PNF in the future as well, to sort of validate a right heart failure specific KCCQ. So that's also in the works. But what you see here is a rapid improvement by a significant margin in the patient's KCCQ score that is sustained out to 6 months. So remembering that an improvement of 10 points, if the KCCQ score goes up by 10 points, that is considered to be a moderate or large improvement in the patient's functioning. And when you see a delta of 20 at 30 days, that's maintained out to sort of 6 months, that's in line with any of the well-known sort of structural heart failure, structural heart disease devices such as TAVR and MitraClip, as well as medical therapy in the HFrEF space. That's the sort of delta KCCQ that you see with devices that are labeled and are in clinical practice. So a very important metric there. In parallel with that, you see improvements in New York Heart Association status. So also very important. Remembering most of these patients present to you in class 3, class 4, and the majority at 6 months are in class 1 or 2, which is very, very important. 6-minute walk test is, it's another important validated marker. It correlates with mortality. These are the data from the Tricus Euro studies. So there was, improvements in the 6-minute walk test by about 40 to 50 meters, which is around about the mark that you would expect, considering these patients, how they were at baseline. Again, all things are moving in the right direction. So based on the fantastic work that the Spanish and Austrian investigators did, we've been very fortunate to work with the company to design and soon hopefully execute with your help the Tricav pivotal trial. This is really going to be the seminal trial that will be used for labeling in North America. The nice thing is that half of the patients are allowed to be not from America, which is really reflective of the fact that the FDA recognize the quality and the importance of data in Europe, where often you have an early experience. And often you guys teach us how to do these cases in America. And so we're going to follow that up with this pivotal trial globally. It's going to be 30 to 40 sites in North America, EU, UK, and Australia, New Zealand. The Cleveland Clinic Coordinating Center for Clinical Research will be the academic research organization in conjunction with one or two CROs. Dr. Kapadia, who's my chairman, and myself will be the principal investigators, and we'll have each of you keyed in each of the major regions for the steering committee. So this is really a prospective multi-center randomized controlled trial testing this device in severe right heart failure TR patients against medical therapy. Remembering that what is medical therapy for severe right heart failure and tricuspid regurgitation? It's diuretics essentially, and then hope for the best. There's really nothing. It's a little bit different to left heart failure, the HFrEF kind of population, where there's a number of medications that really should be used in a step-up fashion. In TR and right heart failure, we really have nothing. The design quickly, as I said, it's prospective, multi-center, randomized. It's the standard kind of features that you see in each of the transcatheter devices in the TR space. It's a one-to-one randomization. We plan to enroll 200 patients. The duration of the study will be up to 5 years. Like I said, up to 40 sites, and half of the population has to be in America. Fairly standard inclusion-exclusion criteria, but there are some things that are specific to CAVI or bicaval stenting. You ought to have severe TR based on a qualifying surface echocardiogram. If you need confirmation with TE or MRI, absolutely. But the decision is really enough on the surface echocardiogram, also looking at the backward flow in the hepatic vasculature. You need to be optimally managed from a left heart failure or left heart disease perspective. You need to be deemed to be high risk by the surgeons or the heart team for a surgical approach to repairing or replacing the patient's tricuspid valve, NYHA class 3 or 4. And the bottom 3 points are really specific to CAVI. You need to have the right anatomy based on CT. Very much like TAVI, we use a CT to plan our cases and to give us the roadmap as to how to do these procedures. Some of the exclusion criteria, probably the most important one is the patient really needs to be on long-term, perhaps indefinite oral anticoagulation, either with Coumadin or one of the newer agents. Very, very low ejection fraction patients in the pivotal trial will be excluded. Your systolic pulmonary pressure has got to be less than 65 millimeters of mercury, and you need to have had your left-sided or pulmonary valve disease treated adequately in the last sort of 2 months. Primary efficacy endpoint, this is going to be based on a hierarchical endpoint, which is sort of in vogue these days with the pivotal trials we see in the cardiovascular device world. So this is 4 levels of hierarchy using the win ratio, all-cause mortality, alternative tricuspid valve therapy, annualized rate of significant heart failure encounters, which is not necessarily just a heart failure admission. When you look at the sort of working statement released by the heart failure community in the European Heart Journal, patients who are admitted not for less than 24 hours to the emergency department or who receive in the office IV diuretics, that is a significant heart failure encounter, and that's an emerging endpoint you'll see sort of start to become embedded in these heart failure trials. And the last or the 4th level of hierarchy is an improvement in the KCCQ score of at least 10 points. Safety endpoints are at 30 days, are fairly self-explanatory and are consistent with most of the pivotal trials in the tricuspid space. There are a bunch of secondary and exploratory endpoints that, again, nothing new here, just to sort of let you know that we're going to be collecting a lot of important data. When you put this in perspective, why is Tricav important? Well, the bottom line is we're all involved in edge-to-edge repair. Some of us are involved in orthotopic replacement. These are impressive therapies. These are impactful therapies. And these therapies do have a role to play in some of our patients. The reality is, when probably 70 to 80% of these patients are ultimately screened out for edge-to-edge repair or some of the more pivotal trials for orthotopic tricuspid valve replacement. So Tricav or CAVI with TricValve really hits the sweet spot for these patients. So that's really important to consider. The other reason why Tricav is going to be important is because it really does capture a broader population than edge-to-edge repair. Other than the fact that you need to have reasonable pulmonary artery pressures, you need to be able to take lifelong oral anticoagulation, and your caval anatomy has to be within reasonable limits. The fact that you have an IVC valve that approaches 45 millimeters, not necessarily yet CE approved, but is being used, and hopefully we have that in the pivotal trial, will really allow us to treat the overwhelming majority of these patients that come to us. The nice thing is there are no specific tricuspid valve anatomical imaging constraints. There are no pacemaker lead constraints. The workflow is TAVI-like. The learning curve is extremely shallow and brief. It's really, you don't really need to be an aficionado doing structural heart interventions to do this procedure. This is a straight up and down procedure, as Dr. Hausleiter showed you. The effectiveness of CAVI in treating these patients has been well shown in the Tricus Euro paper released today in JACC Interventions. And the nice thing about this, it is such a scalable procedure to a broad range of patients and operators. So for me, it's not really the question as to whether this is going to work and whether Tricav is going to be a success. As an Australian now living and working in America, I was disappointed to see TAVI change to TAVR. I hope that CAVI does not get changed to CAVR, just like MitraClip got changed to TEER. Thank you.
Rishi, thank you very much. And I'd like now to ask Liesbeth to give her presentation with her experience in Alst. If you can try to keep to the time or bring us some minutes, I would appreciate very much, because we got a number of questions here, so that we can at least answer a few of them, and we're unfortunately a bit of time behind.
I'll do my very best.
I know.
So I'm very happy to present our first clinical experience we have in our lab since we started implanting a TricValve since January of this year. I have no conflict of interest to declare. So as already reached upon, the typical patients that we will treat with CAVI with the TricValve system is the patient with at least severe TR that is rejected from edge-to-edge or transcatheter valve replacement, that is typically symptomatic in EHA 3 or 4 or has had previous hospitalizations despite optimal medical treatment and is not a surgical candidate. It's already shown the values that we use as a cutoff that we need for inclusion as an inclusion criteria for CAVI. The TAPSE needs to be at least 13 millimeters or more, because often these right ventricles are dysfunctional, but you do need a bit of function to accommodate the sudden increase in the RV afterload. As said already, the systolic pulmonary pressure shouldn't exceed 65 millimeters of mercury, and at the right heart cath you want to see a V wave of at least 15 millimeters of mercury. This represents the severity of the TR and the RV dysfunction, but especially you want is to have a nice closure of the leaflets in systole. And then, of course, for final inclusion for a CAVI or TricValve system, with the TricValve system, you have some anatomical landmarks. I will present you the first 3 cases we've done in our center. First of all, this is an 80-year-old lady who has had several hospitalizations. She's in permanent atrial fibrillation and has a severe massive TR and preserved left ventricular ejection fraction. She was rejected for edge-to-edge because of too wide coaptation gap, and on our echo she had a TAPSE of 18, and after intravenous diuretics, intensive intravenous diuretics, she had a PAPS of 33 and a V wave in the right atrium of 17 millimeters of mercury. She had her CT done and she was accepted for CAVI. Here are some images of the per procedure TOE. So this patient was treated in general anesthesia, guided by TOE, where we can see on the left side the SVC valve, and on the right side the IVC valve with nice movement of the leaflets. no paravalvular leakage, and at the pullback tracing you see a nice drop of that V wave again. This patient had a good hemodynamic recovery, although she did suffer from quite a lot of left shoulder pain, for which we started treatment with pregabalin. 5 days later, she was discharged from the hospital, and then we saw her at her 2-week follow-up, and the lady said she had bilateral swelling of the legs, and at the echo we saw some moderate degree of pericardial effusion. Of course, we want to make sure that the valves were working properly. The IVC valves were working good on the echo, but we did this CT to check, and there's no signs of leaflet thrombosis. The valve is well expanded. There's no paravalvular leakage, and it's opening well. So this patient got shortly admitted, also because of some pain that she still had at the left shoulder, and was treated further with her aspirin and NOAC. But she could leave the hospital fast thereafter. At the 1-month follow-up, the patient did not have any left shoulder pain anymore. She felt better. And here on the echo, you can see, of course, there's still the severe TR, but good TAPSE. So after 1 month, we can say that her pro-BNP did increase, but her NIHA classification improved. Now, this patient was then further seen by her treating cardiologist in another hospital, and she did get re-hospitalized 4 months later because of orthostatism, and actually the diuretics were stopped, almost stopped, little dose left, and she felt she was in NIHA class 1, and she felt much better. Our second case we treated is a lady 10 years post mitral valve annuloplasty, who had preserved left ventricular ejection fraction but massive TR, was symptomatic, and she was rejected for edge-to-edge repair because of visualization difficulties with TOE. So she was accepted for CAVI. She had good echo and invasive parameters. This procedure as well went very fluent, and you can see here also a nice drop of the V wave at pullback. Also, this patient did have some left shoulder pain, but she recovered well, and she was discharged 5 days after the procedure. After 1 month, when we look back to her numbers, we can see here a drop of her blood platelets, and that is something that is seen in other patients as well. But it might have to do with the chemical compound of the leaflets, but it's something that is benign and resolves spontaneously. Also in this patient, there was an improvement in NIHA classification, but also this patient got readmitted because of some dizziness spells 4 months later, but we could see there was perfect left ventricular ejection fraction. The pro-BNP even went down, and also here we decreased her diuretic treatment. And then the third patient is a patient post-edge-to-edge repair who had actually a nice result, acute result, but 5 months later she developed a delayed detachment of the septoposterior clip. So in this patient, it was considered not feasible to put in a new clip. Of course, you can do a transcatheter orthotopic valve replacement. So in this case, it's good to have CAVI on our shelf, and she was accepted for CAVI based on anatomical landmarks as well. Again, a smooth procedure, nice drop in V wave. And this lady we actually pre-treated now with pregabalin, so the left shoulder pain was actually very fast under control, and she left the hospital 3 days later. At 1 month follow-up, the patient felt well. On this echo, you can see that there is nice movement of the leaflets of the IVC valve. There is good flow in the suprahepatic veins, and there is respiratory variation in the IVC below the valve. In this lady, we did see a small increase in the pro-BNP, but on the other hand, we saw a nice improvement in the kidney function in NIHA class, and even there are some signs of positive remodeling in the RV and the right atrium at this early stage. So for me, my first experience and the take-home for the clinical follow-up after CAVI is that we did see this left shoulder pain in all of our patients, but we can treat it with pregabalin or gabapentin, and it resolved in all of our patients at max 3 weeks. We didn't have any patients with post-procedure right heart failure, And this is also important that we choose our patients wisely. The transient thrombopenia has been described before, but is benign, and there were no bleeding events in our patients. All of the patients were treated on antico and aspirin for at least 3 months, and the diuretics, the patients were discharged on their diuretics, but it seems that we can actively taper them down after a few months. And as said, we're still in the beginning phase of getting our clinical data, but they're coming to us, hopefully near in the future.
Liesbeth, thank you very much for your presentation. Actually, but there is one question that popped up several times and which I would like to address to Katharina. These are self-expandable valves that you put into the superior and inferior vena cava. How do you fix them, since there is no real calcium like in the aortic valve, in the annulus? And if you have a pacemaker lead in there or defibrillator lead in there, do you still have the capability to fix the valves over there?
Thank you very much for the good question. I mean, first of all, we are talking about self-expandable valves. We are having a certain oversizing when we choose the size of the valves, and this helps us to fixate the valves. In the superior vena cava valve, you can see that there is like a crown in the upper part of the valve that will fix the valve in the confluence of the brachiocephalic, and then the belly will be in the straight part of the superior vena cava. This is why it's very important to have a good quality CT, because we want to choose the patients correctly, and we want to make sure that we have a straight part in the cava just below the confluence and above the pulmonary artery, the right crossing of the right pulmonary artery. For the IVC, it's important that we have the diaphragm where you have the hiatus of the inferior vena cava into the right atrium. The diaphragm gives kind of an anchorage to the upper part of the valve. So if you place your valve there and the tissue-bearing segment has the highest radial force, then you can expect a good anchorage. The second part is the lower part of the valve, which will expand into the vessel wall. Concerning pacemakers, I think our maximum pacemaker leads up to now were 5 pacemaker leads that were still in place. So this is not a problem, because you will simply seal the pacemaker lead between the stent frame and the vessel wall. Of course, you will not be able to exert this afterwards, but you can still place a new pacemaker if needed through the SVC valve. So this is important, because many of our patients have pacemaker leads, and this is no contraindication for the CAVI treatment. And as I said, even if you need to place a pacemaker afterwards, you can still go through the SVC. You might risk a little bit of function, but I think this is acceptable.
Katharina, thank you very much. Now it's time to wrap up this session to keep in time and convey for the key learnings. I think TricValve intervention is a new treatment option, as you have seen, for patients with severe tricuspid regurgitation deemed at high risk for surgery. I think this was the presence in all of these cases that were presented here. From the early clinical experience of the Tricas 1 and the Tricas Euro trials, we see that TR patients show an improvement in their New York Heart Class, the 6-minute walk test, their quality of life, and a reduction in right atrium, right ventricular volume up to 1 year of follow-up. And I think this is a very important information. So the Tricav randomized controlled trial that was presented here is intended really to confirm these beneficial first results in a larger patient cohort, and we are eager to await the results of that trial. With that, I personally have to thank all contributors and presenters here, and also you as the audience who came in here in this afternoon to look at this new technology. Thank you very much, and have a nice meeting further on.